Welcome everyone. This is a joint event of three centers, Pritzker Center for Risk, International Research of Risk, headed by Mortal Perry, who is with us from London, from England, the Center, National Center for Knowledge and Research on Emergencies, and the Minerva Center for the Study of the Rule of Law under Extreme Condition. At least I know the name of my center in a proper way. And it's a great pleasure and honor to have with us Professor Barney Black today. Professor Black from Northwestern University is affiliated with the law faculty, with the School of Business Management, School of Management, the Department of Finance, and the Institute for Policy Research. And his amazing list of publication reflects all these affiliations. Professor Black is one of the founding fathers of Empirical Legal Studies and published immensely in various fields like financial law, malpractice, and medicine. And today he will talk about corona, science, perceptions, and opinions. Professor Black, the floor is yours.
All right, so now I have to do share screen. And is that's open. So share. All right.
You can take off your mask.
All right. Yeah, interesting. So I teach so first, thank you for the invitation. I, emailed, I think, Ronan Perry on short notice, and you were able to set something up. And so I'm grateful for that. My family are now Israeli citizens. We lived here for a couple of years ago, pre-corona, and so come back, every year, but not last year. And so I said, okay, we're here. We're teaching a short course at Hebrew University. Let me go figure out how to meet people and give talks elsewhere. And what do I talk about? Well, I'm going to talk about corona because that's been on everybody's mind and has been a lot of what I've been studying lately. So let's see. Hitting page down doesn't do anything. What does? Hitting page down doesn't do anything. So I need a clicker.
Try enter?
Enter where? Oh, okay. But then if I want to go back, yeah. So going up, okay. So up and downward. Yeah. Okay. Okay. So my goal, and so I'm going to apologize. I'm going to minimize the people on Zoom because otherwise I can't see my own slides. Michal, maybe if people have questions on Zoom, I can't deal with that.
Okay.
Okay. So people on Zoom, thank you for attending. If you have things in the chat, hopefully Minerva or Ido can monitor that, but I won't. So my goal, I was told I should talk for 30 minutes. So I will talk for 30 minutes, and then if you have questions, I'll stop, and if you don't, I can keep going. But I've been studying corona a lot, so what's on the slides will be, if you have questions, feel free to ask me. A caveat: the literature on Mashber HaCorona is enormous. I cannot keep up with it. Nobody can keep up with it. I try, but I will miss some things. I will give you the best information that I have, which is not necessarily the best information that exists. I'll have opinions about many things. Feel free to ask me what's the basis for that, because hopefully I will be careful about having an evidence basis. I'm an empirical legal scholar. I care about the evidence. And okay, what have I been doing for the last year and a half? Well, I've been doing a whole bunch of stuff on COVID. It was like this. I do empirical work. I do healthcare work. We have this big crisis. And so let me study the crisis. Can you check to make sure that my voice is clear on Zoom? It is? Okay. Okay, so down. Okay, so an overview. From bad to good. So the Delta variant, there's still an ongoing wave in the US and Europe. Cases are rising again as it gets colder and people spend more time indoors, which is where all of the risk is, meaning 99.9% of the risk. If you're outside, you're safe. If you're indoors, you're not. Deaths are still very high. We don't know exactly how infectious the Delta variant is. because we don't have a way to measure the transmission rate under uncontrolled conditions. But it's certainly way more infectious than earlier variants. I think if we still had the variant we had last year, we would have reached herd immunity by now. And the vaccine, the virus would simply have diminished to a low level. But Delta has basically overwhelmed what the herd immunity levels would have been. Israel looks much better today. Will that last? We don't know. Right? We'll see. Going from terrible to sad is the extent of vaccine resistance and refusal. Israel is ahead of many countries, but not all. And there's a special issue with the Arab population for sure. The Haredi, I'm not sure about. I haven't seen no data. I don't understand why I can't get data on vaccination rates by population type, but the Israeli government is not putting it out. You're better than the U.S. I'll show you data on that. The U.S. is a laggard among developed countries, and this is just a shame. I think the mortality rate, if you're vaccinated and now have a booster, is probably 25 times lower than if you were unvaccinated. That's a huge difference. Okay, that's the difference between, in the U.S. we have now about 1,250 deaths a day. Divide that by 25 and you get what, 50? That's a huge difference. Things that are okay, treatment once you're infected. We're getting better slowly, but once you're hospitalized, really not getting better very much since last summer. If you're hospitalized with low oxygen, we know enough at some point to give you a steroid, which suppresses your immune overreaction. And the challenge is when. If you suppress your immune system too early, the disease gets worse. But later on, we know to suppress it. That helps. But there's really been no major developments in treatment for the people who are already significantly sick since the summer of last year. There's nothing else we really know what to do that works very well except steroids. Once we get to where you're on a ventilator or on the ECMO machine, you're already in trouble. We're doing our best to keep people off of ventilators, but if we fail, then we sit there and hope. For early infection, many things have been tried. Monoclonal antibodies help if you get them early enough. Once you get to the hospital, it's too late. The idea is to give your immune system an early boost, but you have to get to people early with the monoclonal antibodies. And they are still in, I don't know if there's a limited supply in Israel. I know there are limits in the US. What we're seeing in the US is of the people who refuse to get vaccinated, when they get sick, about half of them say, no, I won't take the monoclonal antibodies either. Okay, so they're just compounding the foolishness of not getting vaccinated. We've seen recent signs of some pills, a good one from Merck, maybe a better one from Pfizer, that seem comparable to the monoclonal antibodies in effectiveness if given early in keeping you out of the hospital. But the supply there on a worldwide basis is very limited and will remain so for some time. Better news, a high percentage of adults are vaccinated, infected for both. The US estimate is over 95%, over 90% if you're age 65 plus, which is still where many of the deaths are. Maybe 85% for everyone. Israel's a little higher, but I'm not sure how much higher if we take into account that at this point, if you don't have a booster, the vaccine is doing you no good against infection. It's still doing you some good against serious illness, but no good against infection. And the booster rates are not as high as the original vaccination rates. We need the booster, but COVID is running out of naive targets. People who aren't infected aren't vaccinated. We're learning that vaccine mandates work, that if you give people the choice of get a vaccine or lose your job, most people will get the vaccine. Some of them will fight, but they help. In Israel, the Tav Yarok surely helps. How much? I don't know. I was surprised to learn that you allow people on campus without being vaccinated. Why? This is just government idiocy. Require people to be vaccinated. Maybe you don't want to require the whole population, but why you want to let students mingle with each other without being vaccinated? To me, this is not smart. On the great side, the vaccines, the mRNA vaccines work really well. The safety profile is excellent. There is a small risk of myocarditis or pericarditis, heart inflammation, but mostly for young men and mostly mild. Of the people who are, it's 1 in 6,000 to begin with. Of the people who end up in the hospital, 95% go home the next day. I've heard of 1 death. I mean, the safety profiles for mRNA are really excellent. The efficacy profile is less excellent. We know that there is waning after 5 or 6 months for Pfizer, a little bit slower for the Moderna vaccine. We're still not sure why. But I saw a recent story today saying there is evidence from Israel now, which was the first to use the booster, that booster efficacy may be waning. I've seen no data. I've seen only a Haaretz story this morning. I haven't seen the underlying study yet, so I can't give you any information about that. But the advice ought to be stronger and ought to be more strongly enforced that, you should get the mRNA vaccine. In Israel, that's Pfizer. You should get a booster. And that's the advice, but it's not really being carried through in terms of dealing with people who say, well, maybe not. Okay, so here's Delta, right? Here's the Delta variant, and you see that between roughly May and June, it just takes over. And this is worldwide. And this is a sign that it is just way more infectious than anybody else. We don't know what R0 is, the transmission rate with no protection. Okay, R sub T is how it varies over time with vaccines and with masks and social distancing and all that. But 9 is huge. Measles might be 15, but 9 is very, very high on a scale of infectious diseases, and means this is going to be hard to fight without continuing countermeasures. Is the Delta variant more severe also if you get infected? Maybe. I'll show you some evidence. Are there other still worse variants coming? Well, we don't know. We hope not, but we don't know. We're still seeing many infections, even if vaccinated. They're less serious if you're vaccinated, but that may not help any individual. So is Delta more severe? Hey, we've had Delta as the dominant wave since June. Why don't we know the answer to this? We should know the answer to this, and we don't. I have not seen good data. I've seen one UK study of the risk if you're vaccinated, and they didn't limit to Delta, and they didn't limit to the MR. They didn't distinguish by vaccine type, and they didn't control for time since vaccination. I look at this and say, guys, you have the data. You could have done a better job. Why didn't you? The US can't because we don't have the data. We don't collect the data on a national basis, but the UK could, Israel could. Israel's done some of the best research on the effect of vaccines, but this one I haven't seen. Okay, so here's a study that I have seen on Delta. This is coming from our Centers for Disease Control and Prevention, the CDC. This is the risk of death if hospitalized, comparing pre-Delta to Delta. And I want you to look at the last column for the vaccinated, because that's the most relevant column, hopefully, for the people in this room. And what do you see? So first you see an idiotic headline from the study saying there's no difference. Well, excuse me. This is pre-Delta. This is Delta for the elderly. There's no difference. What am I missing? This is middle age, 50 to 65. And then if you're younger, the risk seems to be down. Delta seems to be more infectious but less severe for the younger. But the people who are dying are the older ones. The people who are dying are down here. And we still don't have this word just isn't out there in the public. What's out there in the public is, yeah, it's more infectious, but nothing saying it's more severe. And I think this is a real failure of our research and also of our dissemination of research. So yes, Delta appears to be more severe for the elderly. Warning, this is the risk once you get to the hospital. We don't have the data to go from the population to mortality because this is the US and we don't collect the data.
The numbers here are
percentage. Yes, percentages, yes. Right, so roughly double the risk versus pre-Delta once you get to the hospital. Likelihood of getting to the hospital, we don't know.
So does the vaccine make a difference with the benefit of the elderly?
Yes.
For the numbers here, it's what, 18.6 to 17?
If you get to the hospital, so a main effect of the vaccine is keeping you out of the hospital, right?
Once you get there, it's basically the same. For the numbers.
I don't know that, right? Because this doesn't compare. This is, again, once you get to the hospital. There is some evidence that being vaccinated reduces your risk a little bit once you get to the hospital versus being unvaccinated and getting to the hospital, right? But yeah, I know, right? These are the same numbers, right? Yeah, that's right. Once you get to the hospital, the effect of the vaccine seems to be helping your body get ahead of the virus. And if it fails and you end up in the hospital, then
the rubric of people who just
you're just in the general population anymore. And so I wish that was better news. But it is what it is. This is one study. I've seen others saying you still have some additional protection once you're hospitalized, but it's clearly limited. Most of the benefit is helping your body get ahead of the virus to begin with. Same idea for the monoclonal antibodies. They help your body get ahead of the vaccine. But if they don't work, once you're in the hospital, they're not doing any good. Okay, so this is going to be comparing, and I'll give you another study with a next slide with deaths. What I put on here is the U.S. This is U.S., and then I'm going to give you another slide comparing U.S. to Europe to Israel, okay? So these are the, 1, 2, depending on how you count, 4 waves in the U.S., and where are we now? So we are coming out of a Delta wave, maybe, right? But heading into the winter. So this looks small, but this is in fact a meaningful rise in cases, about a 20% rise in cases. And I can tell you in the northern states, it's 50 or 75%. So the US is heading into a winter wave, without a doubt. And then the hospitalizations and deaths will follow the number of cases. Whether you see that in Israel, we don't know yet. So this is US versus Europe versus Israel per 100,000 people, 7-day moving average. You have to take an average because the daily counts fluctuate. And so here are the Israeli a little bit, again, how do you count the waves? So by number of cases, Israel looked really terrible in the summer and has come way down. The US Delta hit later, it's coming down, but different data sources. This one doesn't pop back up, but the other one is more recent. And Europe is looking quite bad.
This is just infection, right?
This is just infection, okay? But notice here, Israel is way above the others. Let me put deaths on the next slide. Israel is doing much better in turning infections into people who survive. Why? I don't fully know. Part of it is a younger population on average than the US or Europe, but only part. You're doing something right in the trenches. One of the hidden pieces is the mortality rate once you get to the hospital in the US varies tremendously. We don't know why. Well, it's clearly the level of care, but what is it that people are doing? I don't know. I don't even have data. It is so hard to get good data in the US. I've been trying for at least 6 months to get data by hospital so I can run a study, and I can't get the bloody data, right? I've been communicating for months to the Illinois Department of Health, and they say, we're too busy studying corona to give you the data so you can study corona. Okay, I can do a better job than you can, guys. We don't know, but we see huge variation across hospitals in the percentage of people who, once they get to the hospital, survive. I don't know if you guys are seeing that. I would love to see that data. It must exist.
We could, if you want, we have a ongoing project with the Ministry of Health.
Let's talk later. Yeah, I would love to get some of the Israeli data because there are questions I want to ask that some of the questions are being asked by good researchers, but others aren't. So let's talk afterwards if you can, sir.
And can you correlate between, say, socioeconomic area, like population around the hospital and the death rate, or even that? Like
I don't have the data by
Not even-
hospital. We have data by race and ethnicity. I'll show you some data by socioeconomic status, but correlating that with a hospital, in things we know well, like cardiac mortality, some hospitals do a little better than others. I think there are hospitals with a 20% death rate, and I know there are hospitals with a 5% death rate. The differences are huge. The smaller hospitals, some of them are the small rural hospitals in the US, just don't know what they're doing, right? And it's not like there's a checklist. So Northwestern is one of the best in the country, it turns out. I've talked to the people. What are you doing that makes a difference? And the answer is, we don't know. We see the same research as everybody else. We're doing something right. They've been doing it since the beginning, but they don't know what it is. They're just treating patients individually and deciding case by case. And we don't have any good guidance. And then you get to places where hospitals get overwhelmed. And that was the big Israeli worry here, right? Was the hospitals would just get overwhelmed, and then the death rates are going to go up. And we've seen some of that in the United States. So I'm sorry if I'm talking too quickly because it's English. Let me know. Okay.
A question about from the three indicators: death rate, hospitalization, and infection rate. The last one, infection rate, is the least reliable.
Yes.
And all the findings are related to the infection rate. The Israeli infection rate is very, very, the numbers are very high, maybe because there are more tests. And
yes.
So how can you correct for that?
I don't know. The only way to correct for it is to study what proportion of the population has been infected and then compare that to from antibody tests, and compare that to the proportion with confirmed infection from the PCR test, and then get a sense of the undercount. I have not seen that done in Israel. I have seen estimates in the US of a ratio of 4 to 1. We are trying to do our own study in the Milwaukee area to try to get that data, but that's just one little area in the US. I think
in
that
a sense, you have to correct the reported infection rate by the percentage of tests being conducted.
not by the percentage of tests, because different people are getting tested, right? I mean, it doesn't help you. So Northwestern tests students all the time, right? But you need the population level. So yes, I would like to correct these numbers by the to adjust for undercounting of infections. I don't know how. I have not seen the data. The U.S., I think the real numbers are 4 to 1. Maybe Israel is only 2 to 1, right? But so if I took this and boom, 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 it would be up here. But where would Israel go to? I don't know. Where would different countries in Europe go to? So you're absolutely right. We have bad data on actual infections. We know we're undercounting. We know we're undercounting by a lot, and we don't know by how much. But still, Israel is not looking nearly as bad for mortality. I would love to see whether you see the same hospital level variation that anecdotally I know we see in the US, and I don't have the good data. Okay, so COVID has been a disease of the elderly. I'm going to show you data saying that's less true today. So this is US data by age over time. Again, I have not seen Israeli data. If you know of similar data, please tell me where to find it. I have not seen recent Israeli data. So over 85, the green line was the highest earlier. Notice what happens once people get vaccinated. The green drops and it's now below 3 other age groups. Older people, they're still around. We haven't killed them all with COVID, right? Killed a few.
We're working on it.
But mostly they're getting vaccinated and we're learning to be more careful and stay out of the way, right? Whereas the spike now is the highest is 65 to 74. They're not as at high risk, but they're out and about more, and they're less likely to get vaccinated. So we're seeing a real shift in the age distribution of mortality.
Do you know that? It's 65 to 74.
Yes, in the U.S., yes. Israel, the original vaccination wave, you got to like low 90%, kind of age 60 plus. I have not seen the data on the boosters. I've seen aggregate data, but I haven't seen it broken down by age range for the booster shots. And you see for younger, so what I've done here is this is everybody, and the blue line is age 0 to 44. Okay? What I'm going to do is expand the scale, right, and go to younger ages. And so the numbers are smaller. This is now for 100,000, right? No, I went up. This is what I wanted to do. Yeah. So that one was up to 9,000. This is up to 1,000. But the last wave for, where is it? People 35 to 44 is way worse than we saw earlier. And again, I have not seen comparable Israeli data. I haven't seen vaccination rates with booster now, which you would need by age, but I suspect that there are many more younger deaths in Israel as well. There certainly are in the US. This used to be a disease of the old and even the very old, and I heard lots of people say, well, okay, you're 85, you're going to die of something anyway. That's just not the case anymore. Cumulative US deaths by age, again, I haven't seen the Israeli data. You can see the 65s and the 75s catching up to the over 85s. Right, the age distribution is changing. 0 to 44, expanded scale, again, much bigger rise in the Delta. Okay, mortality across countries. So this is Israel. This is the US. So on an international scale, whatever you've done wrong in terms of keeping people alive, Israel has done relatively well. What I've given you also is Europe. I've given you the UK, which is, this is the UK, and this green line is Italy. Italy is the highest mortality rate in the European Union, okay? And they were ahead of the US, but we've caught up in a race that you don't want to win.
Do we know what's going on in Africa? Because I read somewhere that it's kind of bizarre. Mortality rate.
We have no good data.
No good.
I just have not seen respectable data. Ukraine, where almost nobody's getting vaccinated, and they're paying the price for that, right? Especially in the Delta wave, you're seeing a huge spike in Ukraine. So these are just sort of a set of. So Sweden was an interesting case where they decided not to do hard lockdowns. And the behavior wasn't that different. The Swedes are relatively law-abiding. People were wearing masks on the whole, right? I have a daughter who lives in Sweden, so I kind of know what's going on. They didn't look great relative to Europe early on. So where is Europe? Europe is here, right? And Sweden is up here, but in the long run, they didn't do so badly. Right? Maybe they did better economically. Yes. So even if you try to stay open, if you get to where your hospitals are being overwhelmed, you have to do something. And so they got to where their hospitals were overwhelmed in early 2021. And it would be better if governments would act before their hospitals get overloaded. And I think the Swedes mostly did. In the US and a number of states, we didn't. Right? But Sweden doesn't look terrible here. Okay, world vaccination rates. So the purple line, this is Israel. You were ahead of the world early on. And where are you now? Well, not bad, but right, you could be doing a significant amount better, because the goal is 100%. And exactly what the hang-up is and what the vaccine hesitancy is, I don't know. I'd love to see this broken down by population. And again, if you know of data that divides between Arab and Jewish, to which you have to include other, right, who are the people who the Orthodox rabbis don't count as Jewish, and if there were separate data for already, I'd love to see it. I have not seen it. But Israel is looking okay on vaccination rates, and we'll see how you do on boosters. I haven't seen good booster data. This is vaccination data by age from the US, where I have the data. For some reason, the highest rate is 75 to 84, then 85, but after that, it just strictly declines with age. Younger people think that they're less likely to die, and they're right, but right, less likely doesn't mean no risk. Worldwide, who else isn't getting vaccinated? This is for me, a discouraging chart. Why? Early in 2021, we were short of vaccine supply. And so we were ramping up supply, and this is the supply ramp up. More and more vaccine doses are being produced. Then it levels off, and then it even drops. Why? The manufacturers haven't forgotten how to make vaccines. The challenge now is getting vaccines to people. And in the developed countries, that's because the people don't want them. And in the emerging markets, in the low-income countries, that's because they don't have the distribution. They just don't have the logistics to get the vaccines to people. That's why you see these numbers dropping and bouncing around. There's no reason otherwise why it could not have continued to go like that. It would be much closer to getting the world vaccinated. I think this was a real shortcoming of the US and other, larger developed countries in not investing in. We didn't even need to invest in production. We need to invest in logistics. And we didn't do it. What we had was a lot of talk. We'll give you some vaccines by the middle of 2022. Well, that's not what we need. We don't need the vaccines. We need the logistics. We need the boosters. We're seeing more and more evidence in Africa that countries are saying to the COVAX, stop giving us vaccines. We don't know what to do with them, right? We don't have the logistics. Logistics is a major issue. It takes major investment. The investment hasn't happened, and it won't happen. You can't turn it on. You can't turn a switch. Okay, Europe is looking quite bad right now. Hospitals are at or near capacity in several countries. Austria has engaged in an interesting experiment. They decided to lock down only for the unvaccinated. They have the ability to tell who they are. The US doesn't, Israel does. Berlin is taking the same approach. They found this to be politically viable, whereas many other countries have not been willing to be, I think, harsh enough on the unvaccinated. Okay, next topic, vaccines and boosters. And then again, tell me when you want me to just stop and you can ask questions. So the US has Pfizer and Moderna, which are the mRNA vaccines, and also Johnson & Johnson, which is what's called a viral vector vaccine. So the mRNA gives your body a small bit of RNA, which tells your body to make spike protein. Your body then develops antibodies to the spike protein, which should help fight off the coronavirus, because the spike protein is how it attaches to cells. The viral vector vaccines, which include J&J and AstraZeneca, take a non-harmful virus, a chimpanzee virus, let's say, add spike protein onto it and give you that. And then your body develops antibodies to the chimpanzee virus and to the spike protein. And hopefully that will protect you against the corona, which is spike protein. That's the second strategy. The third strategy, which seems to be very effective, is from Novavax. They've had struggles getting regulatory approval, but their phase 3 trials are excellent. And they just skip the mRNA step and just give you spike protein, which has the advantage of being highly safe, much less risk of an adverse reaction. As I said, their clinical trials were very strong, and they've just struggled with getting regulatory approval in the US, which I think we work too hard on jerking your chain about manufacturing capacity and so on. And I'd like to have another effective vaccine in the mix. By effectiveness, Pfizer, Moderna, Novavax might be comparable. We don't really know. It looks so in phase 3 trials. The viral vector vaccines are not as good. And then that includes the Russian Sputnik vaccine. And the worst are the kill virus vaccines, the Chinese vaccines. They just don't work very well. All of these are 2-dose. Johnson & Johnson decided they were going to go out and get approval for 1 dose. That's fine. They got approval for 1 dose. It doesn't work very well. Nobody in their right mind would take the Johnson & Johnson vaccine. Oh, well, they tried. Yeah.
So the virus, kill virus, the Chinese vaccine is not as effective. Why don't we see a resurgence in China, or we see one we just stop reporting? So
the Chinese have been enormously harsh on non-pharmaceutical interventions. They are trying to vaccinate their population. I think if they let the virus in a major way, they would have a major crisis on their hands. We don't have good data on the Chinese vaccines, interestingly. They haven't released it. What does that tell you about how well the vaccines are working? We have limited data from other countries, and it looks like they're just not, this strategy is not as effective.
I think they're being used in Brazil.
Yeah, so the data that says they're not as effective comes from Brazil, right? But if there was better data, I trust the Chinese would have figured out how to get it to us, right? So I infer from the data that they haven't provided.
That the Moderna booster lasts longer.
Moderna vaccine effectiveness lasts longer. We don't know why. One hypothesis is the initial dose is 100 micrograms of mRNA versus 30 for Pfizer. Okay. Initially, the effectiveness was the same. Initially, people thought, take one, take the other, doesn't make any difference. Moderna lasts longer, but it might mean that you need a booster after 8 months instead of 5 months. The effectiveness is still waning, right? The Moderna booster, they're only recommending 50 micrograms, which they think is enough. Is it really enough? We don't know. We don't have the data. So right now, in hindsight, if you could have picked one vaccine, you would have taken Moderna, but you didn't have the benefit of hindsight when Israel went with Pfizer in early 2021. And the effectiveness of the booster dose, we don't know. It might end up being the same thing. The Moderna has more longevity than Pfizer, but we don't know.
So the booster is same quantity?
Same quantity for Pfizer, half quantity for Moderna. So Pfizer is 30, 30, 30. Moderna is 100, 150.
So still 20%.
Yeah, so still substantially more, yeah. Maybe because of the higher dose, you get higher myocarditis risk. Looks like 2 to 3 times as high. This has led a couple of European countries to say if you're male and if you're under 30, get Pfizer. To me, the myocarditis risk is so low that if I also knew, yes, but Moderna is more effective, I'd probably still go with Moderna. But there is a somewhat higher risk of myocarditis, which is the main side effect. But again, it doesn't kill you. What's weird is there's a good Israeli study saying basically if you want to die of myocarditis, the best way to do it is don't get vaccinated and get COVID. Leave aside all the other things COVID does, right? So this is from the original Pfizer trial, right? This is now old data, but this is sort of the Pfizer vaccine trial in one slide, right? And so up to maybe 10 days after the, this is the first dose, right? No difference. After that, right? You barely see the infections, and the solid dots are the severe ones, and you see almost none of those, right? So if we still had that level of effectiveness, we would be very happy. So early on, we had like 95% protection against symptomatic infection in the trials, in the early studies, even better against hospitalization and death. No meaningful evidence of transmission by the vaccinated. 6 months later, basically no protection against being infected. I'll show you some data on that. Maybe there's some remaining protection against transmission to others and reduced protection against hospitalization. As you said, Moderna is still better, right? And lots of transmission by the vaccinated to other people. So message, we still need these non-pharmaceutical interventions, masks, avoid travel, restaurants, gyms, avoid indoor spaces, especially crowded ones. Worry a lot about ventilation. That's been way undervalued. If you're going to be indoors, ventilation matters. There ought to have been a major investment in upgrading ventilation that just hasn't happened. I don't think it's happened here. It's happened a little bit in the US, but all private. I go to the law school and say, okay, ventilation is important. Tell me about your ventilation. And the dean says, I've asked, and they tell me we meet the ASHRAE standards. Okay, how many air changes per hour in this room? Answer, I don't know, right? That's what I want to know before I go into a room with a bunch of other people. But I don't know that, and I bet you don't know that. Ventilation is hugely important in indoor spaces. So here's why we think there is no more protection from Pfizer after 6 months. So this is the end of July, just before you started the booster campaign. Percent of cases vaccinated and percent of population vaccinated. These numbers are substantively identical. We're just not seeing any protection. Now, this isn't adjusted for other things, but it's adjusted for age, right? And so this is very convincing evidence that there is no longer, after 6 months, protection against infection. There is still some protection against serious disease. Differences by vaccine type. So this is US data. And on the left, you've got a raw scale. On the right, you've got a log scale. I'm an empiricist. I can deal with logarithms. Most of you probably can't. So the yellow is the unvaccinated. This is J&J, 1 dose, not so good. This is Pfizer. This is Moderna. There's very clear separation in mortality rate depending on what kind of vaccine you got. An aside on Israeli data, there are things I'd like to know about Israel. I've told you some of them. Let's talk later. But much of the best research on vaccine efficacy comes from Israel, which also means we know much more about Pfizer than anything else. You've got good data, you've got good researchers, you've got this lovely competition between the Israeli health ministry that sees the whole population, Clalit, which sees half the population but has a better research design. Maccabi is trying to compete with both of those, and there's some of the hospitals are coming out. Wonderful data on the effect of vaccinations, and you're really informing the rest of the world about now are we seeing evidence of waning of boosters. The UK has national data and has some good studies. They can't figure out how to report separately by vaccine type. I don't want to know a mixture of Pfizer and AstraZeneca. I want to know Pfizer separately. I want to know AstraZeneca separately, and they will not report that way. They can't keep the data.
Privacy, but also they don't want to generate, since everything is done top down, they don't want to create pressure. We want this, we want that, when they can't accommodate for the pressure.
They have enough. At this point, they have enough Pfizer that they can.
Right.
And they're allowing people to get AstraZeneca first dose and Pfizer second dose. And lots of people are, because the people understand that Pfizer is better, right? For the booster, they're recommending Pfizer. They have the data. They could release the data. It drives me nuts that they won't. Every now and then you see a study. The US has huge problems aggregating data, but we do see more studies by vaccine type. The problem is, we have a big population, but we can't aggregate the data. Is the need for a booster surprising? Well, we hoped COVID protection would be more durable, but it turns out that many other vaccines require an additional dose spaced in time after the first one, right? There are a bunch of them, right? So this was not a surprise. Maybe it should have been better publicized at the time of, look, get the vaccine and we'll find out in 6 months whether you need another dose. But we didn't see that then. Early evidence on booster efficacy. The only data I've seen is from Pfizer, basically from Israel. Moderna is probably similar. We get close to recovering the initial vaccine efficacy of 90 to 95% against symptomatic infection, and better than that against hospitalization and deaths. So most deaths so far have been the very old, the immune compromised, the severely comorbid. How long will the booster protection last? We don't know. Right, so we saw this study from Hebrew University suggesting there's waning after about 4 months in Israel, but I haven't seen the data. There was reason to hope that it'll be longer lasting because of the experience with other vaccines, but the reality is we don't know. Hybrid immunity. If you're infected and then vaccinated, that seems to be better than just being infected, and it's better than just being vaccinated. It looks like 1 dose is enough. I don't know whether you count as fully vaccinated in Israel if you're infected and get 1 dose, or you still have to get the boosters. The US has ignored this and said fully vaccinated means you have to have 2 doses, even though there's evidence that what the second dose is going to do is mostly make you sick and not help you with COVID. But we are too clumsy to figure that out. Would it matter if you're infected then vaccinated, which is where all the data comes from, versus vaccinated then infected? Don't know, because we don't have enough cases of vaccinated first to be able to study yet. So here's a nice chart. This came out before we knew about waning of vaccination. just an overview of how vaccine effectiveness works. And what you do is, so this is meant to be the response to infection, but it's also going to be the response to vaccination. There's an early response from the IgG immunoglobulin antibodies that kicks in very quickly. The slower ones are the IgGs. I'm not going to worry about what G means versus M versus A for this audience. But notice where this tails off. 6 months. Wow, right? That's what's happening, right? After 6 months, your IgG tails off. Your body is designed to retain these memory B cells and T cells, which are supposed to kick in if you get infected and generate more Ig. But what's happening with Delta is it's multiplying so fast, it's just getting ahead of the body's response in generating a new Ig response. That's at least my big picture interpretation of what's happening with Delta. Booster take-up rates. So here's what I have in the US. I have not seen data by age in Israel. I'd love to, right? Once again, the older people are getting the boosters. The younger people who aren't getting vaccinated aren't getting the boosters either, even if they got vaccination, right? Now, partly, we had mixed data. We had mixed messages from our regulators until we still have mixed messages from our regulators. But 50 to 65, 18 to 50, people are not yet getting much in the way of boosters. And this is the Israeli data. This is all I've seen. This is percent of the vaccinated who are not 100%, who get a booster, who are nowhere close to 100%. So if you think the vaccine is no longer protecting against infection, for infection rates, this is the number that counts. The number originally vaccinated really isn't helping very much anymore. And so this is leveling off at maybe 70%. That's not a very good number. I'm not sure why it's leveling off so low and what can be done about it. Do the boosters help? Subject to waning. So here's one piece of Israeli evidence. Just counting the number of people hospitalized. This is pretty crude data, okay? No controls for age, no distinguishing between vaccinated and booster versus just vaccinated. This is people in the hospital, not new entrants, because that's how they count, how many people are in the hospital. But still, if you do just a simple comparison of rates, you get mid to high 90s efficacy of being vaccinated, most of whom have boosters. Okay, so this is soft evidence on booster efficacy. Okay, who's dying of COVID? This is US data from my own research. Mean age of death, the median will be higher, but will show the same trend. So look, through 2000, mean age of death was 80. Okay, the median was even higher because you can go a lot more below the mean than above. And we've dropped a lot, right? So this is down to, for women down to 72, for men down to about 69. What's going on? That's the people who aren't getting vaccinated. Vaccination rate drops with age, and therefore, of the people who still die, they on average die at younger ages. That is purely, I think, vaccine effect. Conversely, if we measure years of life lost per decedent, it was in the range of 12 or 13 on average. Okay, it's now up to 18. So that's a meaningful jump in the number of years of life lost. This is no longer, okay, you were 84 and you were going to die of something, right? This is many more of the new decedents, many more are younger. Let me do this by race ethnicity. From the US, I do not have the comparable Arab data. And so this is Hispanics, this is Blacks, this is Asians, this is whites. These are our four major ethnic groups, right? And so you see the drop across the board. Hispanics were already dying at much younger ages. Not entirely sure why. Partly it's a younger population, but that's not the whole story. But they are dropping again in the fourth wave. Let me turn that around.
How can you explain the dip here? Asian
Data. There aren't that many Asians who are dying. That's just noise, right? That's not. I'm not giving you confidence intervals on these. I don't think that's meaningful.
One, if you can conclude in a few minutes, so we have
yes.
some time for
okay, sure. Just to tell me when to stop, because I can keep going for a while. So mean years of life lost per decedent. So the average Hispanic is now losing 26 years of life expectancy. That's kind of scary. This is no longer a disease of the old, especially for our minorities. And if I had to guess, our population is similar. I just don't know. I haven't seen the data.
It's controlled for the average for Hispanic, not average for general population.
For the years of life.
Yes.
Yes, life expectancy is for the Hispanics, who outlive everybody else except the Asians in the US. So that actually increases the number by a couple of years. Why they do, nobody has any idea, but they do. Okay, so let me do one more riff on the U.S. regulatory response, and then I will stop. So, whatever you think of the Israeli Health Ministry and its missteps, and the Knesset coronavirus committee that couldn't keep the rules in the same place for a week at a time, it seemed, the U.S. agencies have been a complete disaster from the beginning. From early 2020, when they said, don't wear masks, to we can't allow people in the US to use this European COVID test. We'll develop our own. Oops, it doesn't work. So I guess we have no way to test anybody, which lasted for a while. The J&J booster, the J&J one-shot vaccine isn't very good. We know it isn't very good. The CDC isn't willing to say so. They say, take a vaccine. The FDA at least approved the J&J booster for everyone because they know it isn't very good. The population knows it isn't very good. Nobody's taking it, but our regulators aren't willing to say so. With regard to boosters, until last week, the FDA and CDC approved Pfizer and Moderna boosters only if you're over 65 or you're health compromised or you have a high-risk job. They're now allowed for everyone, but only recommended for age 50 plus. And as best I can tell, it's, well, you have 5 times protection against death. That's good enough. Who cares if you could have had 25 times? 5 times is good enough for you, right? Because you're not at such high risk. I think it's complete insanity. At least they're now allowed. As of a week ago, I was going around telling people, I don't care what the FDA says, right? If I'm in an academic audience, you're a teacher, go to the pharmacy, tell them you're a teacher, you'll get the booster, they won't ask any questions, right? Just go get it. But we're not seeing the booster take-up rate because we're getting mixed signals from a regulatory agency that ought to know better. And I will, one more slide. Micro behavior matters a lot. So this is just a micro comparison of the Northwestern Law School to the similarly sized Northwestern Kellogg School of Management. Same number of students, same rules, everybody's vaccinated. These are the weekly counts at Kellogg of new infections. This is the law school.
Don't study business.
The law students are willing to behave like adults, and the business school students are not, right? And I'm sure you have the same thing in different populations, right? Some, I was walking around outside. There are some kids out there indoors wearing no masks. I'm sure they're violating a university rule, but no one's policing it. Okay, questions?
You can sit there and then
Sit here.
yes, next to Eddie.
Next to Ellie. Okay, but you don't want me to go back to my slides. Okay. Go ahead. Since I can't see the chat.
Okay.
Like,
I'll ask. First of all, it was fascinating. At the emergency center, we're now doing we did a lot of COVID studies, but this current research is looking at localities. And the idea was to look at emergencies, what tools are needed to better allow localities to manage. And we're looking at the COVID data. And one thing that's very odd is that there are a number of localities that have over 100% vaccination rate.
sure.
So, when you're looking at data, it's, and then, we try to figure out why. Well, maybe because they're using partially census data for the number of, which is older, for the number of residents per locality, and the vaccination rate is from the ministry. But I mean, there are so many questionable, like in some localities.
That's because sometimes you reside in one place, but you rent in another.
Renters,
it's a
right,
renter.
and there's no way of finding that out, but still, it doesn't give a lot.
I've tried to give you the best data
Yeah,
I
yeah,
have
right.
on vaccination rates. There's another source I could have given you that says in this state and that state, there's 99% vaccination among the over 65s. And all that tells me is you have a bad denominator or a bad numerator or both.
Right.
Yes. So getting consistent data has been and
It's challenging.
continues to be a real challenge.
Yeah, it's
Right?
true.
And the U.S. on the whole is much worse. I can't give you vaccination rates by race and ethnicity. I know that they're lower among Blacks and Hispanics. I don't know how much lower. Why? We have data on race and vaccination by race and ethnicity. The largest group of vaccinated is white. The next largest group is unknown. They don't report. So I don't have, right? I have the denominator, I have the population, but I don't have the numerator. So unless I assume that the unknowns are randomly distributed, I really don't know. So I see news reports reporting on, there don't seem to be big differences by race and ethnicity in the US, but I haven't seen it broken down by age and I don't trust the data.
Right. And then there are these qualitative studies, which are very interesting about why certain groups will or will not
Yes.
vaccinate.
Yeah.
in the States.
Yeah, no, there is, for all the U.S. publicity about the suspicion of the government in Republican states, there is huge suspicion among the Black community, especially.
Because
Yeah.
it's historic.
This is. I'm sorry, I was very active. I'm sorry, but this is fascinating. I want to ask two questions related to the relationship to regulation. The first is if you hear what's this guy's name from Stanford?
Platacaria, probably.
No. The guy who was asked by President Trump to
Charles Atlas.
Atlas.
Yeah.
His data seems to suggest that many things are an overreaction. Heard him speak and give data that the FDA should have been less interventionist in the sense.
Well, the FDA wasn't interventionist. The FDA was reactive. To which my response is, we have roughly 760,000 confirmed deaths. Excess mortality, which the waves in excess mortality correlate, because you could get COVID and die of something else, or it could not be recorded properly, is probably close to 1 million. How should we have reacted? Come on, guys, right? So yes, Trump found a nutcase to support his view that he didn't want to do too much, but the guy is still a nutcase.
Okay.
Right? He's not an infectious disease specialist.
Okay, but my actual question is, not that I trust his data, there is a question in Israel that doesn't relate to, that says that the starting point of the analysis is you have to have one of the key factors of fighting a disease or any emergency successfully is trust. Yeah, you got to maintain public trust, and that's why I started with Atlas, because Atlas basically from the podium of the government said, don't trust this data, I have better data, this is wrong, this is not true. And then apropos mixed messages. In Israel, the immediate reaction to the COVID has been really a very strong lockdown, including stuff that you cannot really rationally explain. Don't go to the beach, don't go outside to nature. So most people complied, but still, but at a certain point, you begin to lose kind of has there been any attempt to correlate the measures adopted by states and then the propensity to vaccinate or the propensity to adopt other measures such as masks and stuff related to the harshness of the rationality of the initial steps?
Really not. So first, most of the messaging is at the national level. So, and most of the states did roughly similar lockdowns at roughly the same time. To the extent we see differences in vaccination rates now, Is there a political variance to that, with some mostly Republican states having governors who are saying, yeah, you should get vaccinated, but if you don't, who cares, right? At the level of not only not going to allow vaccine requirements, we're going to prevent employers from having them.
And then you have Florida.
That Florida, Texas, a few other states, that correlates with lower vaccination rates. So that doesn't fit with the, you have to trust the government. Did governments make mistakes? Yes, right? Did the outdoor restriction in Israel ever make sense? No. Did we know that? Yes. Right? Did we need much stronger protections indoors against aerosol dispersion? Yes. Did we know that a year before our regulators admitted it? Yes. There were good, convincing, compelling studies. And I think that the US CDC, and even more the WHO, didn't want to believe in aerosol transmission because it was so scary. The evidence was compelling as of February or March of 2020.
It's just denial. It's just
it was just maybe it's this, maybe it's that. Well, yeah, maybe, but maybe not. Why don't you take the evidence at face value and say, this is a real risk of a major source of transmission, right?
And therefore you need masks and ventilation and all that.
And therefore you need masks, and you better start investing in ventilation in March of 2020, rather than, as best I can tell, never. A few private businesses are doing something, right? I believe my law school is doing something. But what they're doing, I don't know, right?
Just a quick follow-up on this.
Go ahead.
Maybe we'll give the Zoom participants. Ronen wants to ask. Hi, Ronen.
You're on mute. There we go.
Yeah. Hello. Can you hear me?
Yes.
Okay. Thank you. Thank you for the great data. I have perhaps two questions. In the last few days, a very interesting allegation was made public in the UK. The allegation was made by no other than the CEO of AstraZeneca, and he argued that the relatively, I would say, relatively good position of the UK vis-a-vis other European countries should be attributed in part to the fact that it was using the viral vector vaccine in the early stages of the vaccination campaign. So is there any data supporting this argument? And my second question was, this is also something that is based on research made in Cambridge University and was publicized in British media. They are now doubting some of the measures taken in the early stages of the pandemic, arguing that they are not as efficient as previously thought, including social distancing. If I remember correctly, one of the arguments was that.
Let me do it one at a time, okay?
Okay.
Second question. Let's talk about AstraZeneca. Right. So what I said was the mRNA vaccines beat the viral vector vaccines. They do. The data is very clear. I have more slides if you want. I can show you the data, but I was asked to stop. Okay. 2 doses of AstraZeneca is better than 1 dose of Johnson & Johnson. Are 2 doses of AstraZeneca better than 2 doses of Johnson & Johnson? We don't know, because nobody's getting 2 doses of Johnson & Johnson, right? But the data on waning of AstraZeneca is the UK better off that they had AstraZeneca in early 2021, where otherwise they would have had nothing? Yes. Should you take AstraZeneca today? No. If you got AstraZeneca, should you boost it with Pfizer or Moderna? Yes. And I don't care what the CEO of AstraZeneca has to say. The data on that is very clear. There is a nice study out of Sweden where they allowed mixing and matching of vaccines. The US is now allowed mixing and matching of boosters. We still won't, for some stupid reason, allow mixing and matching of original vaccines. But their evidence, and again, they have national population data. I have some problems with how they collected the data, but they see the same thing we're seeing elsewhere, which is Moderna beats Pfizer, beats AstraZeneca. Okay? But the mix of first AstraZeneca and then Pfizer is as good as Moderna. mixing and matching, which gives your body a different kind of shock and develops a different immune response, seems very much to be the way to go. And, I don't have the UK data from the UK Health Ministry. I know that their recommendation is if you got AstraZeneca, get a booster with Pfizer. I don't know what that's based on. I would like to know what it's based on. I would like them to release the data. But yeah, the CEO of AstraZeneca is happy with AstraZeneca. Yeah, I'd like Johnson & Johnson's CEO to come out and say straight out, we should have had a 2-dose vaccine to begin with. They virtually said that when they asked for permission to have a booster after 2 months, right? I'd like to see them say that officially. I'd like to see the CDC say publicly, Johnson & Johnson isn't as good. Do something else. But they're not willing to do that either. They are willing to say, if you got Johnson & Johnson, get a booster with something else. But booster, your choice. Pick what you want. Well, no, you shouldn't pick what you want. There's good data. And with regard to public trust, I think it hurts when you say things that aren't true. And it also hurts when you don't say things that are true, that everybody knows is true. Nobody in the US is getting Johnson & Johnson anymore. Hardly anybody. We know that. It's like 3% of the population. But that's based on no advice from the CDC. It's just based on, okay, the word has gotten out, not based on people reading the scientific articles. So sometimes we need our regulators to be willing to say something that is true or that we think is true based on the best available data, rather than say, oh, but Johnson & Johnson is approved. We can't say it isn't as good as the others. Okay, so what was your second question?
Unmute yourself.
You're muted. You're still muted.
The host muted me, so okay. My second question was, most of your research, and understandably so, focuses on the impact of vaccination on infection and mortality rates and so on. But there is some research on the impact of NPI, right? Like
yes. Got it. So here's what we know. Let me start, and then you can ask more if you want. Okay. So masks help. Yeah, this is on slides I didn't get to. Right. They help protect others against you by a lot. If you have a good mask, it will protect you against others by a lot.
סטארט וידאו תעשה, אז הנה כאן תעשה, תלחץ על זה.
So, here is a Korean
כן, כאן, רמקול.
KF94 mask, okay, equivalent of the US N95, but more comfortable, designed for long-term wear when you're on the Seoul Metro for 2 hours at a time. These are good, what are called respirator masks. They aren't as easy to breathe through. That's good. They have to be easy enough, but not too good. They're tight around the cheeks, unlike the surgical masks I see all over the place, like, for example, in this room, right, which have nice big holes on the side, which the air comes in and out, going around the mask. The surgical masks are still better than the cloth masks, right, for protection of you against somebody else. With regard to social distancing, if the virus spreads through aerosols, being 6 feet away doesn't help very much. Being in a ventilated room helps a lot. So the early advice on social distancing was based on the bad belief that the virus was spread principally by coughing, by droplets, by big things that fall to the ground within 2 meters. That's wrong. Given that it's wrong, social distancing doesn't help much. Now, having fewer people in a room helps, right? Does it being further away help a little bit? Probably helps a little bit, but that was a wrong view. It's more or less been dropped in the US because there's no magic about 6 feet. There would be magic if it was big droplets that fell to the ground. But for aerosols, that's not the dominant mode of spread.
Alcohol gel? Thank you. Alcohol gel.
No. We thought originally maybe that the virus would live on surfaces. So we were worried about washing your hands and washing surfaces. Forget it. Makes no difference.
You
It's
still need to
still
wash your
part of
hands.
public advice, but it makes practically no difference. I'm not against washing your hands. My wife wants me to wash my hands more often than I want to, but it doesn't make any difference.
Tal has a question.
So thank you very much, Bernie. So I'm wondering if the academic, like legal scholarship or social science scholarship, since the beginning of COVID has been entirely affected. A lot of it, people, including myself, have gravitated to issues of distribution at time scarcity. A lot of it looks at notions of social justice. Was that trajectory helpful, or are we seeing now questions that we don't have an answer for, perhaps because of the focus on that? And a related issue is you were quite blunt saying that, talking about the failure of the CDC and FDA, is that because of too much politics and appointments? Is the lesson here some form of independence? You know, like I'm looking at the stock crash in 29 and then the rise of what came to be the SEC. Obviously, there was not a lesson learned from the so-called Spanish flu in the beginning of the 20th century, which is an interesting question, why we didn't have that. And what will be the lessons now in terms of independence for the next pandemic in 100 years?
So, good question. You know, if you forgive me now that I'm close to you, I'm going to keep my mask on because that's what I believe in. If I was by the window, I'd feel different. Okay. I think that the focus in the U.S. on disadvantaged populations was a mistake. That early on, we had the CDC sort of trying to prioritize different groups. We should have just said older people get the vaccine first and then go down the age range. And I thought about trying to write something that says, okay, right, maybe we give you a boost. We go by age range and we have an adjusted age, and maybe if you're black, you get plus 5 years. That would have been illegal, but it's not plus 30 years, right? It should have been, you know, some modest boost. The risk was all by age. Right? It really was. That was the dominant source of risk. I'm not saying that being black and Hispanic is at a high risk. It is. I could show you data. Again, it's in my slides. I didn't get there. But the dominant risk was really by age. With regard to vaccine distribution, one of the arguments against the U.S. approving boosters was the world needs our vaccines. Well, no, the world needs our help with booster logistics and isn't getting that help. And the talk about they need our vaccines was a sideshow. So there too, I think that was counterproductive. I think what might be productive is an effective way to go out to the minority communities and say, guys, more of you are dying because you're not getting vaccinated, in a way that would be convincing, because that is in fact true, right? And I showed you some data on Hispanic years of life lost. And I'm thinking about working on ways to get that message out into the Hispanic community, and maybe it'll have an effect. So it's not that the disparate outcomes aren't real, but the way that we respond to them has to be not, I think, in the sort of clumsy ways that the U.S. has used. And, you know, so for you guys, what's the story with getting the Arabs vaccinated? How do you do it?
You have special so-called projectors that work on it. You go in.
Yeah, but it hasn't been working that well. Maybe it hasn't been enough effort.
It depends on waves. There were waves where the Arab population responded well, and then they saw that the overall is okay, and then it's more complicated than that.
It is complicated. So in the U.S., the most vaccinated place in the U.S. is Puerto Rico. They're poor, they're Hispanic, and they're vaccinated because they had a very effective public campaign. They didn't have political pushback, right? So it's not all about ethnicity. It's not all about poverty. A lot of it is about effective public messaging. And we've been pretty bad about that, and it doesn't sound like we've been fully successful with that.
What about the independence of the regulators?
I don't think that's a solution.
But it was part of the problem.
I don't know, because I look at what the CDC is doing now, where I don't think they're under, to the extent they're under political pressure to approve boosters, it's like I want to say yay, because that's where the data is, right? And the same for the FDA, moved fast on original vaccines. Is going back to being its old, slow, bureaucratic self, right? And more independence is not the solution to that, right? It is, in theory, not an independent agency. If President Biden wanted to say you should approve boosters, he could. He's choosing not to for political reasons, right? The head of the FDA is choosing not to. But more independence is not what we need out of the FDA right now. What we need is more coordination among the different branches of government. Right, and so whatever its missteps, the Israeli Health Ministry, which is a single centralized, non-independent agency, has done a better job by far than the U.S. complicated Schmigeli. So I don't think independence is the way here. Was there pressure by the Trump administration on the CDC last year? Yeah, but that doesn't explain this year. Right, it really doesn't, and that doesn't explain why the CDC. And the NIH recommended against masks. It doesn't explain why the CDC refused to approve somebody else's tests, right? It doesn't explain today why this is a good mask, okay? It is the equivalent of the N95. If you want to sell it in the US, you have to write on it, not approved for use against COVID, because it's not approved by the FDA for use against COVID. This is insanity, right? Why don't we know which masks are good? I know, but the population doesn't know. Why don't we get good CDC advice on which masks you have to wear?
Maybe to Europe. Europe is great.
Germany, online.
What?
In Germany, you can wear only the N95.
Right.
In Austria, you could, no, you can't ever. But when I flew through Austria for a connection, I had to change this. They wouldn't let me board the plane without the N95.
Okay.
Let me ask you.
But that's tricky, because some of the N95s are okay, and some of them I cannot wear.
Exactly.
I can't breathe through them.
That's right. What's that?
Right? So not all masks are created equal, but this is just as good, but designed for breathing.
Maybe you wore it for a whole year also.
No, you can tell the difference.
Okay.
You really can tell the difference between, can you breathe through it? Does it keep a tight seal around the side?
You burn it. Like,
yeah.
But if
depending on which it is, you can tighten this around the back of your neck, and if you're to close. But when I teach my class, I do. We don't have good advice in the U.S. And I don't think you have good advice in Israel. You may know, but the advice is wear a mask, some mask, any mask, and they're not the same.
Let me ask you an irritating question.
Sure.
In the past, recent past, there were some medications and treatments that were approved by the FDA, and many years afterwards, they were turned to be lethal in terms of cancer. How, as a scientist, can you assess the risk? You know, not for us, the oldies, but for kids, parents of kids who consider whether to vaccinate them. How can you assess a long-term risk of these vaccinations in light of the past that
So here's what you can say. You can say first, I am not aware of a single vaccine that has had long-term adverse health consequences. You get short-term adverse reaction, they shows up within 2 months or it doesn't. Okay? That's different than pharmaceuticals, which are doing much more dramatic things. This is doing something very simple. It's especially true for the mRNA vaccines. The challenge with the mRNA vaccines is to get them to survive in the body long enough for your body to generate an antibody response, because they're very fragile and disintegrate very rapidly. So the scientific plausibility of a long-term adverse reaction is just not there. It's not just no vaccine has done this, but specifically for the mRNA vaccines, there's no scientific basis for worrying about long-term adverse consequences. So vaccinate your kids, absolutely, and don't worry about it. But you have to know enough of the science. And this goes back to the question of do you trust the government, right? The one area where there is uncertainty right now actually is with the Merck pill, molnupiravir, which does have some risk of being carcinogenic. And Merck claims that they see no supporting evidence in animal studies. But that's not the same thing as there's no biologically plausible channel. There is a biologically plausible channel, we just don't know how big the risk is. So it's really going to be very specific.
What was the famous case the headache against headache that caused birth defects?
Right, but again, that was not 20 years later. There was an anti-nausea drug for pregnant women, and it turns out that giving pregnant women almost anything during pregnancy is really risky, and thalidomide caused birth defects and wasn't tested adequately. But that's not 20 years later. That's when the baby's born.
There's also another anti
That caused schizophrenia and insanity.
This particular one.
and there was one that affected the heart. A lot of litigation on that.
Yeah. So there's this was an anticoagulant.
No, it was against pain, and it affected your heart.
Okay. So there was one that was sort of meant to be a less dangerous anticoagulant. It ended up causing probably more heart attacks.
Yeah.
Still unclear whether you would have been better off taking that and getting less risk of bleeding to death, but it was withdrawn from the market because of the heart attack risk. So, but again, that's not 20 years later. And there are things you're never going to learn in a clinical trial that you only learn when you have the drug out to millions of people instead of 10,000. I don't think
you do know that aspirin is less effective now than we thought it was.
Yeah, we recently revised the advice against taking low-dose aspirin unless you're at a high-risk group, partly based on new data, but partly also based on we're better at controlling heart disease risk without aspirin,
right?
So that the risk you're protecting against is going down.
Alternative,
right? And so I don't think there's any alternative to the science is going to change. And our regulators have to be careful not to overpromise. And maybe the hardest part is for people to understand that science is a process, right? And we're going to make mistakes. We're going to think things are wrong. I think we could have done better at being faster at saying, yes, there's aerosol transmission, right? But hey, we didn't know in early 2021 that we need boosters after 6 months. Nobody knew. Okay, we have new evidence. Now we know. It doesn't mean we were wrong at the time.
Just a quick check. We have to end because people. But just a very quick question on democracy. If in Israel, a huge issue was synagogue versus demonstration. Now, the data seems to suggest that both are dangerous.
No, the demonstrations are outdoors, so they're not dangerous.
No. You can have synagogues outdoors, but synagogues were also told even outdoors you can't do.
Yeah, and that was wrong.
That was wrong, right? But you would.
That was not. Well, let me say, it was not based on data at the time.
Yeah, but you would have expected to see some higher rise in risk in terms of demonstration, because there were a lot of people outdoors, but still a lot of people. I didn't see any uptake related to them. And if we would have trusted former Prime Minister to have made it a very clear, don't demonstrate point, and there's no doubt.
So we knew that by, let's say, July of 2020, because in the US we had all these George Floyd demonstrations, and there was no spike. Right? At that point, we know there's no, and there is a lovely early 2020 Chinese study where they literally traced every single case out of 7,000 cases in Wuhan and did the genetic sequencing. Out of 7,000 cases, they found one outdoor transmission. Right? We knew in early 2020 that outdoor transmission was basically non-existent. And we kept on, you need a mask everywhere. You had lockdowns where you can't go more than a kilometer from your house. We knew better. Right? We knew better. That one I do not understand. I think the evidence that all the transmission was indoors was clear enough early enough. I think the evidence on aerosols was clear enough early. That isn't, yes, science will sometimes change, but that was I don't know. I don't know what yeah.
Last question from
the audience. We have two. One is Shmuel Yerushalmi, if he wants to ask.
So let's collect them and
There is another one from Rotem Barkan.
You hear me?
Yes.
Yeah, okay. I want to ask you, in the side of different problems and risks connecting to coronavirus pandemic, I want to ask you if you see any opportunities creating a pandemic of coronavirus and the crisis in result of this pandemic.
I'm not sure I heard the question.
There are also opportunities.
Yeah, about opportunities that creating a pandemic of coronavirus.
I wish. I have not seen so far good evidence of a proactive international response. I certainly haven't seen any signs that the U.S. isn't going to make the same mistake we did after SARS-1, which is to pretend to have an effective response, but actually not do much and not invest in it. It's kind of like earthquake protection. Everybody knows that Israel should be investing 10 times more than it is in earthquake-proofing old buildings. And it's happening slowly, and you hope there isn't an earthquake too soon. Is that a good response? No. Do you guys know it's not a good response? Yes. Is the government willing to invest 10 times more money in making a better response? No, because it's not a priority today. I think we're going to see the same thing after the COVID crisis. I wish it were otherwise, but I've not seen the signs yet.
Do we have time for another
last question.
Rotem Barkan. Maybe I'll read her question. Is there a mechanism in place in the US that tracks side effects efficiently and will do so for the coming years, specifically for the mRNA vaccines, which are relatively new technology? Israel is lacking on this front.
So we have a system for providers to report adverse effects that come to their attention, right? So you get a vaccine, you don't feel well, something happens, the providers are supposed to report to the CDC, and it is supposed to collect data. Israel actually has good data because you have national data through the Kupat Holim. So the best data on the myocarditis and pericarditis risk comes from Israel. Is it complete? No, because if you don't go back to the Kupat Holim, they don't know, right? The US probably, my guess is our data collection is going to be worse than yours and not better. We have a vaccine adverse effects reporting system. Vaccine adverse effects reporting system, VAERS. So you can Google VAERS. We have it. It's in place. It exists. It's decent. It's cross-vaccine platforms because we have different vaccines. And so there have been some studies based on that. Is it complete? No. Are we missing major things? I really doubt it. We just have not seen people dropping dead of vaccines.
Thank you very much. We have to conclude.
So thank you for the opportunity.
Thank you very much.
So I just wanted to share with you.
Yeah.